Okay, welcome everybody to the MGH Photobiomodulation Clinic round. Today is May 7, 2021. I'm Paolo Cassano. It is my pleasure to introduce Francisco Gonzalez Lima, a PhD and Professor of Psychiatry and Behavioral Science at the University of Texas, Austin. And the title of his presentation today is Cognitive Effects of Transcranial Infrared Laser Stimulation in 5 older adults with bipolar disorder. Welcome, Francisco. Take it away.
Thank you very much. I would like to go straight to the presentation. My outline is very brief, so I will have a brief introduction with a little background and rationale for this particular study, and then show you some of these effects, cognitive effects that we found in this small group of bipolar patients. And then we'll spend most of the time in discussion, and I really welcome all of your questions. So transcranial photobiomodulation, the way that we have been looking at this is being using low power, high fluence light from lasers or LEDs in both animals and humans to develop the background to follow up with these human studies. And we have used in my lab a range for 600 to 1100 nanometers with various effective results, especially the lower range using small animals like rodents. So we choose to go to the higher ends to facilitate the limitation of light scattering that is reduced as you go in this scale, going from visible light to this region of about 1,000 nanometer wavelength. So then we started a program of research introduces using this 1064 nanometer light and has a way to stimulate the human prefrontal cortex and augment cytochrome C oxidase. I abbreviate that here CCO, which then is followed by an increase in blood oxygenation in the human brain. So our first targets were to demonstrate this in vivo after we've done that in animal studies. And as some of you know, this is took a number of years, and we were able to accomplish that. So basically, what we corroborated using this particular protocol is that cytochrome oxidase indeed can be targeted by this laser light in the human brain, that it facilitates its catalytic activities. Here on the left is just a cartoon of the so-called mitochondrial electron transport. And essentially, the enzyme is absorbing these photons, and the photons act as if there were electrons in this electron transport by pushing away electrons away from the enzyme and into oxygen. In other words, the enzyme becomes oxidized by the light process of photooxidation, which is not a mechanism of action that has been presented by any other group. All the groups are just simply talking about light being absorbed by cytochrome oxidase, and we're saying it is photooxidized, and that's why it increases its affinity for oxygen. And therefore, there is an increase in oxygen consumption, ATP production, and also in nitric oxide. I'd like to give a brief series of examples of some of these clinical studies that have been done. Our group has done very little in terms of clinical populations. So here on the left is using LEDs. Most of this work has been done by the groups in Boston, your group, and the other ones in Boston University that you collaborate with. in, as you know, in depression, anxiety, mild cognitive impairment, and stroke, TBI. And most of this has been case studies. So in the case of laser stimulation, this little has been done. The original studies were done with stroke in the early parts of this field. And then in our lab, we try to look at, these were not really a clinical populations, were just individuals with elevated depressive symptoms. And we were trying to see whether we could facilitate this attention bias modification. And then more recently, we done individuals with subjective cognitive impairment. Some of these did indeed have mild cognitive impairment that could be verified by our testing. And we found benefits in some of these applications. And I have been always interested in bipolar disorder, so we were interested in moving into that particular population. This is a population that could benefit greatly from a cognitive enhancement because there is a clear impairment in the prefrontal cortex function, especially in the older adults with bipolar depression. Even individuals who are euthymic, remitted, they present with these impairments. And interestingly, if you compare them with individuals of the same age, they have more of this cognitive decline. There is evidence of mitochondrial dysfunction in this population, which our intervention may be able to target. And as we know, also a consequence of this is oxidative stress and damage that happens chronically in these individuals. And also functional studies show hypometabolism and abnormal connectivity. So we had a number of reasons to focus in this group as a potential beneficiary of this approach. We targeted the anterior part of the prefrontal cortex, and referring to this as Brodmann area 10. And the reason for this is that we found that in the cognitive tests that these people show the largest deficits, they recruit bilateral regions of the brain in this, especially this prefrontal area. And in particular, cognitive flexibility, verbal fluency, working memory, sustained attention, and impulsivity have been verified to differentiate between healthy older adults and older adults with bipolar disorder. So our goal then was to use these techniques that have been able to differentiate between the two groups and see whether we could uh, make an impact of some kind. So we had a hypothesis, but there was largely exploratory by looking at these various categories or cognitive domains. It's interesting that when we selected this, I'd like to draw your attention. In particular, this was from a meta-analysis. And if we look here at the last tags, cognitive flexibility, the TMTB, the trail making test or task B. If you look at the ES, the effect size is the one that shows the largest effect size in terms of difference in deficit between bipolar and other older healthy individuals of comparable age. So we anticipated that perhaps we could make the best results in this area, but we included from the other domains. And in particular, in the field of bipolar research, there's a lot of research done with this continuous performance task for sustained attention and impulsivity, and we were also interested in those two. So in a nutshell, those two tasks were the ones that show any evidence of improvement in our patients. So in terms of more details about the methods, These five participants were 45 years of old or over. I'll show you some statistics later. They have bipolar 1 or 2. At this point, we just wanted to have a few subjects, no history of traumatic brain injury or cerebrovascular accidents, and they were in a euthymic state. They were monitored by our collaborating psychiatrist, Dr. Fink, who when study started was a resident in psychiatry, since finished and in private practice, and in consultation with our director of geriatric psychiatry, Dr. Erica Garcia Pittman. So all the patients were screened and monitored during the study by these two psychiatrists. In order for us in our lab to verify that this mood remain, in terms of manic and depressive symptoms, remain stable over the course of the study, we apply this John Mania rating scale and a general patient health questionnaire. This is the task that shows the greatest difference between the bipolar and the healthy aging individuals. So the very commonly used, the main key measure here is the time to completion from beginning to the end of tracing this particular task. The other ones were verbal tasks. We have a working memory task, delay master sample, that we have used before in probably all of our studies before with this particular protocol of photobiomodulation. And we have this continuous performance task. And in this task that assess impulsivity and sustained attention, we were particularly interested in these foil trials. For example, here an X is presented and the individual doesn't push the X, indicating that they have failed to respond appropriately. So the experimental procedures, so there were like two phases, and the phase A were visits 1 to 6. This was a design that is referred to as a crossover control design. In other words, in phase 1, each patient was randomly assigned to either sham or active laser stimulation. They undergo these 6 visits. In these 6 visits, only in 5 of them, we actually give the laser stimulation, indicated here by tilts, or the sham placebo. Then there was a washout period of 3 to 4 weeks. And then we have a phase 2, visits 7 to 12, where the same procedures are followed. This is a picture here. This is not one of our subjects. This is just a student from our lab that was just modeling there. She has a very small head, and we wanted to show that it was possible to do this. The laser is just held by, she's sitting in what is called an optometrist chair, where we can attach things and hold it in place. So I just wanted to point out that they wear eye protection. The laser is aimed at the forehead. And in this case, there is a headband here where we have sensors to monitor the actual changes in cytochrome oxidase and blood oxygenation. But for this study, we, in these 5 patients, we were not monitoring this. We did follow up with a study with many more patients, bipolar patients, monitoring that, and we just haven't been able to publish that yet. So the important thing here, the limitations, since we have only one laser, so we alternated this laser 1 minute in the right, then 1 minute in the left, right and left, all the way to a total of 10 minutes. So each side received 5 minutes of laser in this alternated fashion. In terms of laser parameters, this was again a 1064. For the CHAM, this laser has a red guiding light because it's invisible otherwise. And so the CHAM had this 650 nanometer light. So the actual individual who was delivering this, we made sure that they didn't know what it was. They only saw a red light coming out, and they didn't know whether it was the red light alone or the red light plus the infrared. And this continuous wave collimated beam, very small power density, 250 milliwatts. The placebo or CHAM light was very small, was 0.16 milliwatts, the equivalent of a red laser pointer. And the dose was 75 joules per centimeter square per site. 150 was the total for that brain area together. The laser itself had a 4 centimeter diameters, and the session was 10 minutes in this alternation. So our hypothesis, and we wanted to have more people, but we had to interrupt this study. But we wanted, in particular, interested to see whether we will be able to have decrease in the time to completion of this trail making test, part B, the one where these patients seem to have the most difficulty. And the same thing, we were hoping to see benefits in this fluency task, verbal fluency task, working memory, and the continuous performance task. In terms of results, this is so that you become a little more familiar with these 5 patients. Here in each column, we list some characteristics of the 5 participants. The average age or average of the sample is at the lower row. So on average, they were about 71 years of age, ranging from 60 to 85 years old. 60% were female. And we had bipolar disorder 2 and 1 individuals, and also different racial groups, Caucasian, mixed, African Americans. And I have to say this group was highly educated, as you can see here, the number of years. For example, this one, the African American was a medical doctor, and others also had doctoral degrees. Austin is a very highly educated community. And importantly, none of them had suicide attempts, which we were concerned not to do any harm during this study. And as you probably know, they always have some of these other comorbid situations, especially depression, and to a certain extent, anxiety. So 80% of them had depression and 60% had anxiety. And these are the medications that were maintained stable during the treatment. I will have to say that the most common way that they were dealing with the bipolar disorder was with an anticonvulsant. And this is the results that we found in uh, the trail making task is where we found some benefit to 4 out of these 5 individuals. Not so in the delay match to sample task. We saw, here and there some improvements, but there were also changes in the other direction. And so has a group, uh, they reduce their mean completion by 8% here. And then in the CPT, the continuous performance test, we also saw some benefits in 4 out of the 5 individuals. And, and the benefits were in these foil trials. The percent correct on average was improved by 11%. As you can see, I cannot do any particular statistics with this small sample. And we saw some other benefits here, but too few to make any speculation at this point. So to summarize in our discussion, impulsivity is an important problem in older adults with bipolar disorder, and has been related to impairment of these risk-reward pathways, and as being manipulated by stimulation of the dorsolateral prefrontal cortex in some other studies. We found the largest effect, the 11% benefit in this measure of sustained attention impulsivity, has measured by this cognitive continuous performance task. And then the other effect was in this cognitive flexibility as measured by that time of completion of the trail making. There is evidence that this, for neuroimaging studies, that the dorsolateral as well as the anterior regions in these particular populations are engaged during this task. We didn't find any benefits for the verbal task or the working memory in these 5 individuals. And we speculated that perhaps the verbal fluency tasks are more lateralized, as shown by neuroimaging studies, and may require more, for example, more stimulation on the left side and probably in a different location than what we were doing. So in terms of limitations, this is only 5 cases. I think our study design also have limitation. The design itself is robust, but when we have such a small sample, there may be a sequence effects, somebody getting the sham before or the laser before may have some impact. We may not be able to detect. However, the fact that it was randomized and crossover, I think it's even if we only have a small group of patients, I think it's better than just don't doing it that way. And also a big limitation is the dosing of the laser. We choose to do bilateral based on the activity found in neuroimaging studies for this particular test in the older individuals. But we really have very little to guide ourselves in terms of the frequency and duration. They were given these sessions once a week, total of 5 sessions. It is an open question whether more sessions per week over a different number of weeks may be a better way to approach this population. This is a major limitation of our study and subsequent work that we do. We don't have a good basis to justify this protocol, or at least not good enough for us. In any case, we are going to continue. We did get a much larger sample. I think so far we were able to do 16 other bipolar patients demonstrating target engagement that we indeed can augment cytochrome oxidase activity and oxygenation to the brain in this particular population. We hope that by doing these kinds of measurements, we may be able to individualize dosing in our more clinical studies. So to try to use a dose that will be beneficial for that individual patient. And we hope in the future also to use other photobiomodulation methods, especially using LEDs that may perhaps use a device that they can take home and do more of these sessions at home. And we are incorporating with our collaborator, Dr. George Almeida, who specializes on neuroimaging of bipolar brains, doing more types of neuroimaging techniques. Now we already done some small pilots showing that indeed we can change arterial spin labeling, blood flow. For example, if we only stimulate the right side, we can see the effect there on the prefrontal cortex. And we want to, we're seeking funding to continue that type of work. So thank you to my collaborators. I wanted this to be acknowledged. My lab manager, cognitive and psychiatric collaborators, graduate students. In particular, I'd like to mention Kearney O'Donnell. This work was part of her dissertation work. And our research assistants, these are primarily undergraduates or post-bachelor's technicians. And our collaborators in Arlington, that has always helped us with the instrumentation aspect. And this was supported by the Oscar Feature Fund that I have been fortunate to obtain. So I also like to thank our patients here. Just they were so gracious. They even sent us thank you notes and cards from this study. So thank you very much, and I'm open to questions at this time.
Thank you so much, Francisco. I think this is a really important work. Your group especially has done magnific work in understanding the neurophysiology in healthy subjects. But as you said, there's something to be said about moving to an actual disease population and demonstrated that target engagement can happen in a disease population. And for instance, in the sample that you selected of older bipolar, penetration might be different and therefore target engagement might be different. So I think you're targeting a problematic that is key about cognitive impairment in this population and finding target engagement specifically in this population. I will open it for discussion. I have a few questions. I see some in the chat. If Nivaldo, you want to ask your question. And Francisco, if you want to close so we can see each other.
Please go ahead.
Nivaldo, do you want to ask your question, or since you're here?
Yeah, I see on the screen. I like to say some people who have been reading their papers, who have inspired me for many years. I like to acknowledge them, like Dr. Margaret Naser over there, Dr. Frederick Schaeffer. I also see my colleague, Dr. Hanley Liu, and many others actually. So thank you all for doing what you're doing and keep leading the way on this field.
Francisco, I'm going to read the question. So what do you think if we were to stimulate more areas of the brain, is it possible to achieve an improvement by doing so?
Mm-hmm. Yes, this is an important question. The Some of these questions I have tried to answer first in animals, and we're still doing that. And Our approach has been to try to find a window to the brain. And we have found that the forehead and the underlying prefrontal cortex is the best window that we can have, at least for the purpose of this cognitive phenomena. As you know, prefrontal base function is a key for most of these functions that we refer to as cognitive function. And they are not limited to the prefrontal cortex, but it's a window that we can use to engage other networks. Thanks to the work with Dr. Hanley Liu and her group, especially Dr. Wang, we've been able to tell that indeed networks throughout the brain are activated when you stimulate for example, just the right prefrontal cortex. And uh, so we choose this right prefrontal cortex also based on, for example, there are studies done with elderly population that show that if you look at all of the cognitive networks and do functional connectivity analysis, in particular, an analysis also of directionality of information flow, that the area of the brain that has the greatest influence on all of the networks components of cognitive networks is the right anterior prefrontal cortex. So even if you compare one way to measure this is, for example, the outflows from each of the nodes in these networks. The largest number of outflows to all of the other components is located there. So based on this work, we don't think it's necessary. At the beginning, as a functional neuroanatomy, I thought I had to stimulate at different parts of the head to target different parts of the brain. But especially for cognitive enhancement, I am more and more convinced that we don't have to do that. If we stimulate the prefrontal cortex, we can engage these networks. And Dr. Hanley's Liu's work with whole head FNIRS has clearly demonstrated this now, and we publish this network analysis. And we hope to do the same thing. We're doing the same thing with more conventional fMRI functional connectivity work. So right now, for cognitive enhancement, I don't think using stimulating the whole head will make a better approach. In our animals, it's we're still learning all of the other effects, comparing older and younger people, younger and older subjects. But I saw all the questions. So,
Thank you, Francisco. I have a follow-up question on this aspect also about localization of the probe. You tend to use FP1, FP2 kind of areas, and so targeting more the frontal poles or the frontal areas of the prefrontal cortex. But you know, some others have used rather F3, F4 and obviously, as you mentioned, the dorsolateral prefrontal cortex is the area of target for the cognitive impairment in bipolar disorder. So I wonder about that choice and if you have thought about using F3 or F4, what's your thinking around that?
yes, we have done both for this. For this particular cases that I showed you, we follow. And by the way, we just centered the laser on FP1 and FP2, and for example, in this case, but it's a 4 centimeter laser, so it really takes care of a broader area. And for sure, all the area that is defined as Brodmann area 10, the anterior prefrontal cortex. However, in other studies, and bilateral, because the elderly population shows this bilateral activation, they are less lateralized than the younger individual. However, for example, we use focusing on the lateral side only, especially the dorsolateral prefrontal. And when we did the study with uh, the Wisconsin car sorting test, which is considered a gold standard in executive function testing. In that case, we targeted that lateral prefrontal cortex, and it was was one of the studies where we found a most clear effect in that population using that target. So the way I see the forehead is you can divide the left and the right in two halves, but then you can also divide each half into quadrants. So potentially, even though you're only targeting the forehead, especially people that have lots of forehead, like me, this age, uh, we can get no interference for absorption by the hair, and we can target, you know, dorsolateral, mediolateral, ventrolateral, and ventromedial regions that provide a rich set of targets for a lot of applications in the future. We have some study that hopefully will be published soon, in which we were targeting more the medial regions, especially the ventromedial regions, in the context of exposure therapy, fear extinction-based exposure therapy. And but let me tell you one thing: even though we've been moving around these targets, we seem to get the best results always on the right side. And for this particular cognitive task, not obviously for the verbal task. And more on the lateral than the medial aspects seem to be more effective.
I've seen that both Paul and Fred have questions. If you want to go ahead and ask your question.
Um, sure. So my question was just to get the background on bipolar disorder for compared to older adults. Do they also show additional recruitment in the PFC, or do they not do? Is the recruitment not there? Is there, in terms of trying to think about how these networks are different between the two groups?
Uh, if I understood correctly, yes, the continuous, yes, these individuals show bilateral recruitment in the anterior prefrontal cortex, which is different, for example, from the young people. The young people doing some of these tasks are
Yeah.
more dorsolateral prefrontal cortex, but the older population, they show less dorsolateral prefrontal and more anterior prefrontal, more on these frontopolar regions. And this is characteristic of healthy older individuals, but also these bipolar individuals. And
Okay, so the bipolar individuals are doing the same thing as healthy older individuals, but yet they're still having problems with cognition and other things,
yes, and there
despite
is
the fact that it looks like they're doing the same as they age. Okay, yeah,
and there
thank
is
you.
a correlation between the more bilateral and anterior the activity that is presented during neuroimaging, the better the performance of these elderly populations.
Yeah.
So the two phenomena are linked, and you know, the speculation or interpretation is that they are compensating by using other networks and expanding their networks bilaterally, as opposed to just use the dorsolateral. So in the younger people, it's more focal, more localized to the right, and more dorsolateral. So and it changes in both. It changes in the amplitude of the activity that you see, and the spatial distribution, so they expand their areas of activation.
So do you think it would be more beneficial to apply to the right dorsolateral prefrontal cortex, just what you would see in younger adults, to see if that might enhance
This is
more?
what we propose to do in our next study.
Okay.
We have verified that just doing it there, we can get these effects on, at least on the cytochrome oxidase augmentation and the oxygenation. And the study that we're starting out with Dr. George Almeida involves the right stimulation and monitoring cerebral blood flow with fMRI, arterial spin label fMRI. So yes, we would like to do that and see. But it is, I acknowledge, it's so difficult in this field with human studies. And I get to appreciate the work, like I say, of my colleagues there, Margaret and Frederick and others that have been doing this with the animals. I was always able to move faster. And there are so many potential possibilities here. And,
Thank you.
I think Fred, you had a question. I see
Yes,
Joe has a question.
As I said in my talk I gave a few weeks ago, in my practice, I found that if I did a simple test, which is just blocking vision like this, so that you're looking out one lateral visual field or the other, what I find is that just doing that, patients have a very dramatic change in their perceptions, and such that they're more symptomatic on one side and less on the other. And it's not consistent, where initially I anticipated that all the bad stuff would be on the right side. It turns out it's about 50-50. So I do this test first, and I have this horrible looking man here that I have them look at as a provocation, and they'll look out one side and they'll say, he looks really scary and he's, raising my anxiety. At the other side, they say, well, it looks like he's laughing, and he's not frightening. And then I go back to the other side and he's upsetting again. And so I use that test, and then I put this is in my general practice, which includes a broad range of patients, but we have two random controlled trials with substance abuse, with opiate abuse, and we've gotten really remarkable results. We had a 72% reduction in cravings and a large reduction in use in a paper that we just finished a study and we're writing that up. And that's the second controlled trial. And what we did was this simple visual test to see which side the person felt better on, and treated the hemisphere contralateral to the visual side, so the positive hemisphere, and we get really remarkable results, and the patient feels much better, and they like the treatment, and have the people are waiting to come back in because I haven't been in the office because of COVID, and so I might suggest that you try that. And
yes, we'll be happy to try that. We don't. I'm very familiar with this work, and I think it's very clever of you to the way you are going around these questions. And we try a little bit, and but more has an experimental question. In other words, in our first study with those individuals with depressive symptoms that was inspired by your initial work with photobiomodulation, and we did have, I made those gaggles
Right.
with half visual fields like you have, and we had our faces. We didn't use your scary face. We used faces that are been validated to evoke these negative emotions on used by our clinical psychologists there, and the idea was to do this as just as an assessment. Do they have the right or the left hemisphere being the one with the more negative bias? Because remember, in that study, we were trying to manipulate or modify their negative bias, and so it's so we then afterwards, we ask the questions when we analyze the data, does it make a difference in the results, whether they show more left or right hemisphere negative bias in that test? And unfortunately, there was a trend that that we found. And in that study, we also stimulated the right and the left forehead. So we target the two different hemispheres. And what we found overall was that the right stimulation facilitated the modification of the negative bias. We go the negative bias in that sample, overall in the sample.
So no matter which side the vision test showed, they did better with
Yes.
right side stimulation.
We then compared to see whether that's, it turns out in the majority of our sample, that was also the same side where they have the negative bias. So even though you say it's 50-50, but it's small samples you have. So we couldn't disentangle the two things therefore, because
Now, did they feel better when they looked out the left visual field?
They didn't show a self-report like they feel better. We have a little scale that was a continuous scale from like 0 to 10, where they had to click on this on the computer, put their mouse on top of where in that scale they have. Before and after presenting these faces. We presented more than one of these negative faces. We also presented neutral faces, and they had to do the same thing. So we just wanted to make sure that it was just not a bias to whatever face they were showing to present that as a score. But in any case, that was our initial attempt because of the overlap between the right and the left stimulation, and the fact that most of them had their largest negative bias on the right. We couldn't disentangle the two phenomena, but the most robust
So the negative bias was in the right hemisphere, not the right visual field.
in the right hemisphere, correct.
Okay.
And but we would like, you still have the little gaggles, all the setup for this. So in the future, we're interested in testing this.
Good. Thank you.
I see that there are three people lined up, Joe and Lee and Sarah. So if we can have very brief questions and quick answers, I want to give a chance to everybody.
Okay,
Joe, do you
who
want
goes
to
next?
go first? I saw Joe, Hallie.
Hi, Francisco. I just have two quick questions. So one is about this crossover. So you will have each of them doing the treatment and sham. So how long do you have the time for them to come back?
To recover, yes, 3 to 4 weeks was between the two phases.
And how many trials? I mean, how many treatment? 5? I mean, 6?
5 weekly sessions.
Just one time per week.
One time per week for 5
10.
weeks. And then they had 3 to 4 weeks in between. And then they started the second session. The second session were also 6 visits, but the first one is always this testing that we do to make sure that they're still stable. And so, yes, this it was taking a chance. We don't know exactly how long these effects last, if there are any. So I wanted for sure to go beyond 2 weeks. So 3 to 4 felt that it was safe enough to do the crossover.
Okay.
And Sarah?
Yes, thank you very much for the presentation. I was just wondering about pulsing, because there's a lot of research, you know, on other devices, and people have done research looking at, for example, 10 hertz and 40 hertz, especially for different conditions. I wondered if you'd considered that and whether that might have an enhanced effect.
Say that again, about what?
About pulsing the light, pulsing at 10 hertz or 40 hertz.
Pulsing, okay, sorry. No, we use continuous light. When you do the pulsing, in addition to going on and off, you are actually reducing the amount of light that you're exposed in a given amount of time. So we have decided based on the animal study, we did the pulsing with the animals. So far, we haven't found any benefit. And I believe one has to be very careful when you do the pulsing. You may end up with 1 or 2 situations. One, you may end up with the same energy density, but in order to achieve that in a less amount of time, because you have periods that is on, other periods that is off, then you actually have to compensate by increasing the power for the periods that is on. And then the other situation is that people do not modify the power, and then they end up with actually less total energy level delivered over the same time period. And some of the animal studies that have advocated like the 10 hertz and so on actually were done in that way. So there was a confound between dosing and pulsing.
Right.
But it's something that with we have a laser now that was custom made for our lab that we can more easily do these kinds of things, any kind of frequency. And for reasons that are not entirely clear to me, whether we do continuous or some other low level pulsing, we always facilitate 10 hertz oscillations if you measure this by EEG. And this is a work that has been primarily done by Dr. Hanley Liu's group. And there's relative to sham, because as you spend time, you know, doing this, the waves change. So you always have to do this relative to a sham. There is a facilitation of the alpha, the 10 wave component, whether you do continuous wave or not. So
Right, interesting. Thank you.
Thank you.
We have 1 minute for a very last question. I see Marnie raising her hand.
It's
Joe,
pretty fast.
were you
Sorry.
okay?
Okay, it's very fast. So I know you're starting to do, you're going to be doing more MRI, and I'm wondering if you're going to, and thank you for your talk. I thought it was wonderful. Are you going to do resting state functional connectivity MRI analyses? So, you know, have you changed anything in salience network, executive function, default mode network, et cetera?
Yes, the answer is yes. We will do that with the ball signal, like most people do, but also with the cerebral blood flow, arterial spin labeling signal. That is a little bit more directly linked to the effects of our manipulation.
Mhm.
Yes, and we would like to answer the question, is there any predictive value for resting state baseline patterns on the responses of the individuals to this intervention? This is a very natural question that we like to look into. And
Right, because you're putting your laser on, your best spot is your right dorsal, lateral or lateral prefrontal cortex here on the right side. And then, but what network have you changed? If you have?
Well, in this pilot study, Dr. Hanley Liu can tell us from the FNIRS, not the fMRI, from the FNIR resting state functional connectivity, the main network, the two networks that are impacted are the default mode network. It's very clearly impacted starting out from this right anterior prefrontal stimulation. And then the other one is this central executive network, the frontoparietal network. Those two in the paper, the last paper with the whole brain FNIRS, the functional connectivity analysis directly demonstrated this by Dr. Wang, that this was the case. In our pilots with fMRI, we found the same. Those two works so far.
Now, which population is that you found that in your bipolar disorder? Or
With Dr. George Almeida with the bipolar, and in a study that we haven't published yet was with looking at young and older individuals, looking at both young and older individuals, and to tell the truth, this is a good thing and a bad thing because if we stimulate this default mode network, these may actually interfere with then performing tasks right after the stimulation. As you know, this is a pathway that normally has a negative effect. When you are engaged in a task, you have
to go back and forth. Default mode network executive.
Yes,
go on and off. Right.
Yeah, this effect was particularly strong in the all elderly group with the default mode network. I think because they start out with less coupling when they are in resting state there. But we haven't published that yet. Yes, and one also has to make sure that if the subjects are having more or less equal performance, that we're not saying that we have a difference, but it's because the subjects actually have different cognitive performance difference, and that's may explain the network being activated. But yes, that's what we're doing, and so far, like I say, with FNIRS, this was validated by the work of Dr. Liu and Dr. Wan that we published recently.
Oh, good. Thank you.
Thank you, Francisco. This was really inspiring, interesting talk, and we'd love to hear new data. Thank you all for joining, and see you soon.
Thank you very much. Bye-bye.
Okay.
Bye.